Muy buen día a todos. Estamos acá con el doctor Pablo Corral. Tenemos el gran honor que nos acompaña el doctor Kosh Rey para dar la conferencia central, que acá se visualiza su título. Yo voy a presentar al profesor Kosh Rey, que es profesor de la Escuela de Salud Pública de la Imperial College en Londres. Es consultor de cardiología, como todos saben, presidente de la Sociedad Europea de Aterosclerosis, es referente o líder nacional de enfermedad cardiovascular en Reino Unido. Yo busqué cerca de 500 publicaciones, es probable que tenga más, y tiene un H-index o un índice H de 103 y más de 170.000 citaciones de sus publicaciones. Esto ha llevado a que desde 2018 figura en Clarivate Analytics, que es, explicó en dos palabras, una entidad que publica una lista anual de investigadores altamente citados. La lista reconoce investigadores de prestigio mundial seleccionados por su trabajo excepcional en investigación, demostrado por la producción de artículos altamente citados que se clasifican en un top one por área y año, y el doctor Coshrey figura en un top 0.1% de autores en el área médica. Así que es realmente destacado. Pablo, ¿querés decir algunas palabras de Koch y damos comienzo a su conferencia?
Hoy es un amigo de la Sociedad Argentina de Lípidos, es un amigo de muchos de nosotros. Es un placer, como decía Laura, tenerlo hoy acá. So, thank you very much, Coach. It's a really honor and a pleasure for us and the entire Argentine Lipid Society to have you participate in our event once again. You are a great friend to many of us and I greatly value your support. So please, Coach, go ahead.
Very much, Pablo, Laura, for the really kind introduction. I'm only sorry that I can't be with you in person because it's been far too long since I've had steak in Mendoza and a Malbec. So I need to return to one of my favorite places in the world. So I'm known to many of you. Many of us have been friends for many years. And you will know that one of the things I've really been passionate about is for us to try and tackle those large-scale problems of our times as a society, as a global group. And this is something that we've tried to do, both from our collaborations like the FH Studies collaboration, and many of the initiatives, for example, the LATAM chapter of the EAS, something that Pablo and I had conceived over a decade ago, which has now come through to fruition. So I want to basically encourage all of you, particularly the younger people, to think about joining together and thinking about how we tackle cardiovascular disease and how it's not just about individual patients, but what we do as a society, the population as a whole. So these are a list of my disclosures. I've been involved with the development of lipid-lowering therapies for over 20 years now. This is the scale of the problem. These are the deaths that occur annually from cardiovascular disease, most of which will be from atherosclerotic cardiovascular disease. We've got better now at helping people survive those acute events. So people go to hospital quicker, they have revascularization, and then they return home, hopefully to continue their lives. The problem is, unless we address what brought them into hospital in the first place, we will not really make an impact in terms of public health, the expenditure, and the health of our population. So many more people, because of some of our advances, will return into the community in a way where we actually probably are doing a disservice. We're not actually treating those individuals aggressively enough to try and manage the root cause of this. And I'll share some of my thoughts with you. So This is from the Global Cardiovascular Risk Consortium, and it's over 1.5 million people. It covers every single region of the world. On the left-hand side, you can see Latin America, and we can see that there are about 5 major risk factors that are modifiable. When combined, will explain about 2/3 of the cardiovascular events that will occur, fatal or non-fatal. Slightly more in men, nearly 60%, about 50% or so in women. But I also want you to look at deaths, and this is important because we often, in our patients and those people that don't believe in some of the things we talk about will say, show me your treatment reduces mortality. Well, the problem is time is an important factor. So if you look at these same factors that account for 50 to 60% of fatal and non-fatal cardiovascular events, only account for about 1 in 5 or 1 in 10 deaths in men and women, because cardiovascular disease deaths are only one cause of many of the other things that one can die from. And importantly, people are more likely to have non-fatal events, fortunately, than they are to die. So we have to refine our thinking. That's the first important point. The second important point here is, again, and you can look at the third column here, global, Latin America. In these studies, what was the average age of the population that was studied? Well, it was only about 54 years. That is peak productive life, paying taxes, contributing to health. Look at the blood pressure, 126 millimeters of mercury. Look at the non-HDL cholesterol, 156 milligrams per deciliter. So their LDL is about 120 to 130 milligrams per deciliter. That's the average at baseline. These are the numbers in our society that within the next 5, 6, 7 years will account for 60% of events that will occur. So this concept of normal or okay clearly is not acceptable when you start to think about genetic vulnerability, when you start to think about good days and bad days, your risk factors, and how long you have been alive on the planet. So these numbers are clearly or should not reassure us as doctors and should not reassure patients. We need to basically do more earlier because these are not safe numbers. Now, we can see here, this is an important study I would encourage you to look at by Amit Khera and colleagues, showing you the impact of genetic vulnerability. And here they looked at low, intermediate, and high polygenic scores in 3 cohorts. A North American cohort, here is a purely female cohort, and here is a Scandinavian cohort. So this provides validation that when you go from low, intermediate to high genetic vulnerability, your risk of cardiovascular events increases. But your genes do not have to be your destiny, because you can see that you are more likely to have events if you have an unfavorable lifestyle as compared to the blue if you have a favorable lifestyle. So knowing that you are more genetically vulnerable throughout your life means you can course correct earlier and you have the lowest events in each of these studies, even when genetic vulnerability is present. But for many, lifestyle is not going to be enough and you need to do more. Now, let's look at the impact of the previous 2 population-based data and how we try and implement it. This is a registry in Sweden. This is the age of first myocardial infarction in Sweden. So the first thing to look at is the average age is ranging between 62 to 66. Now, a key thing here is if you look at the previous slides, you could see that these were the same patients that 10 years previously we were saying your numbers are okay. It's not too bad. And this is what happens. So if you look, for example, at these are quartiles of change in LDL from admission during cardiac rehab, i.e. the 12 weeks afterwards, and looking at the change in LDL and subsequent cardiovascular outcomes. And these are quartiles. That each group represents 25%. Look at the middle group. these are 50% of the MIs that will occur. The LDL is basically about 2.3 to 3.8 millimoles per liter. So if you like, that's ranging between about 90 to about 155 mg per deciliter. Many people would not consider that to be hypercholesterolemia. It's just pathological for these people. And if you look at 75% of the population, look at the day, the month, the year before, the vast majority of these people were not on cholesterol-lowering medication, meaning nobody thought this was going to happen to these individuals at the age of 64, when 10 years earlier, people were looking at these individuals with these very same numbers. So we have a problem about prevention, which inevitably makes us treat disease and not preserve health. If you will, that's the prevention paradox. The next thing I want you to look at on this slide is the first time these 75%, their body ever sees a lipid-lowering drug is after the MI. And the LDL target for these people is 1.4. You can see that with a single drug, where you get to, it's around about 1.8, 1.9 millimoles per liter. So we need to think about this concept of monotherapy or combination therapy. Keep it really simple. We can make it more complicated when we start to say things like high-intensity lipid-lowering therapy. They are, for the average doctor, very hard to understand, and for patients. Mono, combination, one drug, multiple drugs, very simple. Then you look at this group. Let's look at them more closely. They came in with an LDL of around about 2.1 millimoles per liter, so about 80 mg or so per deciliter. And they, after 12 weeks, the LDL did not change. They had a stent put in. But what we've done is we've saved myocardium. We've not dealt with the process that brought them into hospital. Why would you have an MI with an LDL of 2.1? Well, you'd have an MI with an LDL of 2.1 because these people would have had a prior history of myocardial infarction, for example. They have more risk factors. They're on lipid-lowering therapy. So they've had an MI despite statin therapy and an LDL of 80. That's too high for them. And when you basically look at how they were managed, they had the worst outcomes. The red line, MACE, mortality, myocardial infarction. So this is a problem with health system implementation. Okay, so we created the World Heart Federation cholesterol roadmap not to talk about hypercholesterolemia, but to talk about cholesterol lowering as some part of the solution. How much lowering you need depends upon where you are in your life course, how late you've started, whether you have multiple risk factors that make you, or you have genetic vulnerability. So it's a document that's worth reading, and it's open access. And it basically sets out our aims with this particular slide. This is the disease that you and I are interested in. It's called atherosclerosis. It starts in childhood. It progresses over many, many years and decades, and it occurs in the vessel wall without symptoms for the vast majority of people until it no longer causes symptoms and you present with an MI or you die for an MI in about 50%. So we have to basically think about this as our target with our patients and amongst ourselves. What we want to do here when your blood vessels are healthy to stop you even getting this process is going to be very different from the population who are 20, 30, 40, walking around. They already have some disease, and we want to stop them progressing to this. And then we've got these people who have more advanced plaque, more advanced disease. They will not benefit from the public health and social policies that we put in, but they're our problem right here, right now, and higher risk because we can't turn the clock back and go back in time. So you have this third of life, this third of life, and this third of life as your approach. Cholesterol can only get into the wall of the blood vessels through three particles. These all have, they're very easy to remember, they are all ApoB containing lipoproteins. They have one ApoB on the surface of the lipoprotein. Cholesterol doesn't mix with water. It has to be carried in lipoproteins that enable them to be carried around in the bloodstream. The vast majority of ApoB is in what we call the LDL particle. Therefore, the vast majority of ApoB and LDL and the vast majority of cholesterol sits in the LDL particle. And if you like, the vast majority of atherogenic cargo is LDLC. So this is why this is our principal target for treatment. Now, blood levels don't really change with exercise. You can improve this a little bit if with diet and lifestyle, but when your levels are really very high, so above 190 mg per deciliter or 4.9 millimoles per liter, the likelihood is either has a monogenic or a polygenic basis. And the difference is going to be how long the levels have been high. With monogenic from birth, from polygenic probably later in life. So think about these as smoking and pack years. You have a 50-year-old with a monogenic basis, it's like having 50 years of smoking. If it's a polygenic basis, the LDL elevations probably start to go up in adulthood, meaning it's like smoking for 30 years. So we can use these analogies. You've got to think on the right-hand side about diabetes, obesity, because these people will have insulin resistance. You see this as elevated triglycerides, but remember, next to triglycerides is cholesterol. So divide triglyceride by 2.2 for millimoles per liter by 5 to get the cholesterol cargo in milligrams per deciliter. And when triglycerides are high, remember our principal target should be either ApoB or non-HDL cholesterol, because there's a lot of cholesterol here. But this can be improved quite significantly with weight loss, reducing alcohol intake, and better control of diabetes. In some, there may be also a polygenic etiology. And then in the middle, we've got lipoprotein A, which carries less cholesterol compared to the others, and the levels are entirely genetically determined because it's this additional portion for ApoA, and that's under genetic control. Lifestyle doesn't really make a difference to this, and I'll talk about this later on. Now, this is important because when you get the full lipid panel, we don't need multiple fancy tests necessarily. You need to know what the HDLC is, you need to know what the triglycerides are, you need to know what the LDLC is, and you need to know what lipoprotein A are. Because patients 1, 2, and 3 will all have the same non-HDL cholesterol, but those 3 different particles, the amount that is present will vary. But in all cases, the principal first target before you start chasing triglycerides and LPA is lowering LDL cholesterol. De-risk the patient by taking that off the table, because the vast majority of the particles and hence the cholesterol is here. The others are relevant as well, but take that off the table. And we do that through increasing expression of the LDL receptor. And most of our treatments either make more LDL receptors or make them live longer. Now, I want to talk a little bit about, again, our delays in primary prevention and time. Future trajectories of risk matter. So here is another important study. So it's looking at a range of our traditional risk factors, which we've discussed already. It's looking at the distribution of those in children and adolescents, following those people up and looking at events in early adulthood. And so in childhood, if you're this is where normal doesn't make any sense. If you are 1 or 2 standard deviations from the average, we call that a Z score. So you can look at individuals where there's not a number specifically that is magical. You look at the natural distribution and say, am I in the middle? Am I a long way away from the middle? And being a long way away from the average is a bad thing here, because you can add all of those different risk factors and count the total number of Z scores. And you can see in relative terms, the hazard ratio, the more risk factors you have, the further away you are from the middle, the higher your risk. But when do those events occur? Not necessarily in your 20s, because event rates are very low. But over time and unopposed, the people that have the highest traits already 20, 30 years earlier from the normal, from the average, will have those higher risks. So that's important. So this whole thing about should I treat people earlier? When you look at this, what would you want to do if you knew your future course and your destiny? You'd want to avoid this. And the time to do it is early, not late. Now, you've all seen this, but let me give you another version of this. So everybody shows this and says this shows cumulative exposure is important. What do we mean by that? So this is not looking at LDL levels on treatment, but what you change. 1 millimole, 40 mg per deciliter, 2 millimoles, 80 mg per deciliter. Over here, the age at which you are making the change is about 59. Will you have more or less atherosclerosis? More. Therefore, over 5 years and a 40 mg per deciliter lowering, starting at age 59 with a lot of atheroma, the return on investment is only 22% risk reduction. But over here, you have lifetime, genetics, Mendelian randomization. And now what you can see is starting with those normal clean blood vessels, that same return on investment, but starting with clean blood vessels over 50 years is giving you a 50% risk reduction. And somewhere in between are these people where they've got some disease, but they're about 39 now. And over 12 years of follow-up, the return on an investment of 40 mg per deciliter is about a 33% risk reduction. Put another way, if I draw a line estimating lifetime 22% risk reduction, I could draw a line that goes across like this. Meaning, in childhood, if we change through diet, lifestyle, public health policies, LDL exposure by 15 mg per deciliter, which is doable, clean blood vessels, 52 years, I will change the life course of all of those people by 22%. It'll be lower. If I only do that later, I wait until somebody's 39, then I need a little bit more. I need about 28, maybe 30 milligrams per deciliter, and I need to maintain that for 12 years with a little bit of atheroma already present to get 22%. But if I wait until 59, I need an even bigger amount. The return I need to get 22% is now 40 milligrams per deciliter if I want that benefit over 5 years. Because at 59, I don't have the luxury of 50 years of treatment because I'm probably going to be dead. So Brian Ferentz produced these data for the World Heart Federation cholesterol roadmap, extrapolating these principles even further. We've got two individuals separated by a difference of 50% in LDL, the dotted line and the blue line. And you can see that events don't occur straight away. So what happens? We see these individuals, we say, hey, you're okay, you're young, you know, go away and try a bit of diet and lifestyle. What does this person do? They'll go back home, talk to their wife. The wife will say, how was the consultation? What did the doctor say? And he'll say, the doctor says I'm young, nothing to worry about. And he carries on working. And then this is what will happen because they don't engage with healthcare now because of this consultation here. At every age that we bring people in to engage with healthcare, we have an opportunity for change. This is making a change in 50% in LDL starting at age 60, 50, 40, and 30. And this is the relative risk reduction, 27%, 37%, 50%. You can see how much you're bending the curve. But remember, by starting earlier, there is less disease and you're going out longer. Therefore, you have a much bigger opportunity to make changes. But on the right-hand side, you can also see that those targets that we use for more advanced disease may not be relevant when we start earlier, because we can see that starting at age 40 and achieving a 33% LDL reduction gives you much greater benefit lifetime risk-wise than starting at age 55 and now needing a 50% reduction because you've waited 15 years and now there's more disease. And you can see that from the cholesterol treatment trial list. These are 5-year event rates. And so 5% over 5 years is 1% per year, 30% over 5 years is 6% per year. Why do event rates go up? More disease, more plaque, more risk factors, more genetic vulnerability. Look at the return on investment when there is less disease, when you are lower risk. That is exactly the time to intervene because now 1 millimole or 40 milligrams per deciliter is giving me nearly 40% relative risk reduction. What happens if there's more plaque, more events? The return on the same investment gets less, meaning if I take somebody with 6% per year risk, I need not 1 millimole, but 2 millimoles to try and match the relative risk reduction that I would get over 5 years in this individual. And on the right-hand side, you can see that nature doesn't care how we lower LDL cholesterol. This is bempedoic acid in the CLEAR Outcomes trial. Primary prevention, 0.78 millimoles or 30 mg per deciliter. So similar to this second line here, because the placebo event rate was 1.6% per year, which is similar to this group here. Over 3.4 years of follow-up, the relative risk reduction is 36%. This is very similar to what we saw with the statin. So nature really doesn't care how we lower LDL. And this is, again, further Mendelian randomization data showing you over a lifetime what you get with a 1/3 millimole lowering of LDL cholesterol, so about 15 mg per deciliter, with the statin, ezetimibe, or PCSK9 type of approach, and you get very, very similar risk reductions over 50 years. But you only need a small amount if you start early. Nature doesn't care how you do this. We've got trials that, again, support this. So we know, for example, sometimes people will not be able to tolerate higher doses of statins. When you double the dose of a statin, you only get 6% further lowering of LDL. And so what in this Korean study called Lodestar that was shown is that you could use a lower dose of a statin with ezetimibe and achieve the same LDL as trying to ramp up monotherapy. And you can see here the LDLs are very, very similar. It's a randomized trial. If the thing that we are trying to change by two different approaches is the same, we can see what the outcomes are because of randomization. LDL the same, outcomes the same. So again, nature doesn't care how you lower LDL cholesterol. But the problem that we have is our implementation. This was Da Vinci. This was looking at this particular slide is looking at a group with ASCVD, asking the question, what is your approach? Monotherapy or combination therapy? And you can see the vast majority is moderate to high intensity statin monotherapy, with combination therapy only used in 10%. So when you look at the goals for this group, 1.8 in 2016, 1.4 in 2019, so equivalent to 70 mg per deciliter in 2016, 55 mg per deciliter in 2019, that you are more likely to get to below 70 mg per deciliter with more potent statins, but you're getting only 45% to goal. When you add in a second drug, combination therapy, more people get to goal. But when you're aiming for 55 mg per deciliter, only 1 in 5 will get to goal with statin monotherapy. Of those left, an extra 1 in 5 will get to goal with ezetimibe, but that leaves us still with about 50% not at goal. And for those individuals, we may well need PCSK9 directed therapies or oral agents like bempedoic acid. Now, I'm not a fan of talking about hypercholesterolemia, but there is one group where we can think about hypercholesterolemia, and Argentina and Latin America contributed significantly to the FH studies collaboration. So FH occurs in 1 in 311 individuals. It's present for birth. What this slide shows you on the left-hand side is the average age at which it's diagnosed. It's 44. Of those adults that we have, less than 2% were diagnosed before the age of 18. And that is exactly the time we have to diagnose them, because their bodies have not been exposed to LDL for as long, cumulative exposure. If you delay the age of diagnosis, what will happen to the prevalence of conventional risk factors in addition to that high LDL? Will you have more hypertension? Yes, you will. This is age of detection, diagnosis, that goes up. What about diabetes prevalence? That also goes up. BMI goes up. So if you find kids, then you can potentially reduce the likelihood of lifestyle factors that will also accelerate their risk of atherosclerosis. And by the time we find these people, about 17% already have ASCVD. How should we manage them with combination therapy? These are the proportion of people getting to different LDL targets in the FH studies collaboration. And here we've broken it down by the proportion of people getting to target with different approaches. So FH patients inevitably need combination therapy. And if we start earlier, then in some countries where maybe the injectable therapies are harder to get, we can avoid those because we can start with 2-drug oral combination in childhood and maintain that, avoiding the need for more expensive medications later in adulthood. We can see that screening in childhood, this is the second major paper that came out from the FH Studies collaboration that you've contributed to, also published in the Lancet. And these are percentile curves. This is the bottom 5% distribution and the top 95th percentile. And here are non-FH individuals. You can see that even without genetics, just using LDL cholesterol levels early in life, where there are no other lifestyle factors, you can find these children potentially with FH, potentially then think about treating them. And if you find the kids, the average age of their parents are going to be between 28 to 34. That means they are less likely to have atherosclerosis. By finding a child, you can find a parent, and then you can offer the parents now, as a result, treatment as well, much earlier than the average age of 44. You gain 10 years. Think about time, and time for public health. Now, this contributed to the Prague Declaration a few years ago, basically advocating globally we should move towards universal screening before the age of 18, ideally at birth, but if not, in early childhood and adolescence, certainly by the age of 18, because you've got time to course correct. Now, if you do that, this is what happens. This was a study from the Netherlands showing individuals who had FH diagnosed in childhood, started on statins, and during follow-up, their LDL came down. You'll say it's not perfect, but the important thing is time. Look at their siblings. Their siblings with age, we will derive with lifestyle factors, LDL will go up. But what we've done effectively is we've normalized this difference by bringing this down much, much earlier. And as compared to parents, the grandparents died of cardiovascular disease. The parents maybe survived, but they had disease and they were found late. But the children are found before they have disease. And they're starting that treatment early as compared to their parents, for example, gives you much better survival and freedom from events. What about lipoprotein A? With lipoprotein A, inherited factor, and people get very nervous and scared that we can't do anything about it. But the events don't happen overnight. They take time. So finding, again, those individuals means you might avoid this trajectory where LPA is unopposed. But what do we do if I can't change this with medications or diet and lifestyle? Well, one thing you have to think about is this. LPA and risk do not occur in isolation. We have to think about all the other conventional risk factors as well. So the person with a high LPA, for example, with high global risk, the way to reduce some of the excess CV risk is to bring them here, control all other conventional risk factors so that even if the LPA is 350 nanomoles per liter, the event rate is here, not here. So global risk matters. Brian Ferentz, as you know, a once in a generation intellect. This is what he created. All his work, deep causal AI. It's open access. You can use this to manage your patients. The screenshot at the bottom shows you how you can access this. You can enter information on your patients. How do we use this? Well, the basis of this, again, is this principle of global risk. There are two things that will tell me how much LDL I need to lower to offset the risk of a high LPA. One is the level of LPA. The higher the LPA, the higher the atherosclerosis risk. And secondly, what is the age I'm making that change? So if LPA is high, I need to reduce LDL more than if LPA is lower. But if I start late, I'm also going to have to achieve a much bigger reduction in LDL, both to offset the level of LPA, but how late I've started, 60 years versus 30 years. And what is created is this. This is your lifetime trajectory using conventional risk factors. If your LPA level is high, your true risk lifetime may not be 33%, it may be 52%. But what do you do about it? So what you might do about it is bring their LDL down and bring their blood pressure down. And now, instead of this lifetime risk, you've brought it down above 50% to now close to 30%. What about triglycerides? Triglycerides are still very much of a mystery in terms of where we target drug treatment. What we know is VLDL, which contains triglycerides principally, these are short-lived. They evolve and become small LDL particles. So when you look at your lipid profile, you're not looking at like for like. The triglycerides are like stars that have just been born. Your LDL particles are stars that have been around for a long time. Most of ApoB is in LDL rather. So the options are, we can either improve clearance of these particles. Fibrates only change the content. The prominent trial didn't show an improvement in clearance of these particles, but maybe in the future, ANGPTL3 and ApoC3, which give you reductions in ApoB, and also which reduce LDL cholesterol, may be the way forward. But also, the other thing is, why not make more LDL receptors with combination therapy, statins, ezetimibe, and with an injectable therapy? Because you can wait for these particles to evolve into small dense LDL and enhance their clearance. We've shown that before. So I wanted to finish with population health. What would an implementation strategy look like? And these are the 8 pillars of the cholesterol roadmap. Atherosclerosis starts with the retention of cholesterol-containing lipoproteins throughout your lifetime. And how much lowering you need depends upon where you start. It's multifactorial. It's not just about lipids. You've got to basically think about other risk factors as well. They enhance the accumulation of lipids in the wall. So you have to think about risk stratification, because most people will develop cardiovascular disease without very high levels of LDL and other risk factors. FH is the only scenario we think about hypercholesterolemia. Screen for it. Like number 8, screen for LPA. If you find it, you can start treatment earlier. We now know that LDL can be lowered by multiple different pathways. The amount of benefit depends on the absolute lowering and time. We can move towards ApoB in time, but I think getting that full lipid profile is really helpful. LDL will still remain our principal target for treatment, but with an increase in diabetes and obesity, non-HDL and ApoB may become relevant. But this is part of the solution we need to think about. Look at the global distribution in billions that we've got across the world. So if you look at, for example, the public health policy targeting the under 20s, if you look at the public health policy targeting the 4 billion here in this age group, 20 to 60, and then the fewer people we've got with more advanced disease, they would be very different. And what we need to do is this. These are the events that will occur in the short term on the right hand, on the top bar here. Look at the numbers we're talking about. So for the young, the children, the adolescents, public health policies focused on screening, primordial prevention, stop the risk factors for developing. In this middle group here, raising public awareness, think about cumulative exposure. We've got cheap treatment, statins. If we start early, we get a bigger return on investment. The problem is, these people think they're immortal. They don't engage with health service. And for those people here, where we don't have the opportunity to turn the clock back, they're our problem right here, right now. Combination therapies. And if we, instead of looking at 5 years, we start to think about all the events that will occur over the next 50 years, these people here are a very small number of the 8 billion people. The return on investment in primordial prevention over the next 50 years will be huge. The return on investment on health awareness and early primary prevention will be huge. And these people that we worry about with more expensive treatments right now will be a drop in the ocean if you put it in the context of everybody else. And if we do that, instead of our healthcare costs just going up and up and up, and we just treat disease, you cannot have enough ambulances and hospitals and trained cardiologists that's going to cope with a growing population of 8 billion. If we change to preserving health, our health resources will be managed in a better way. And in time, we will actually prolong life. We will avoid in many people cardiovascular disease and will improve the quality of that life with health savings. So in conclusion, think about cholesterol lowering throughout the life course to reduce the burden of ASCVD. How much lowering depends upon where you start, the risk, and the atheroma burden and risk factors driving this. Primordial prevention, screening for FH and LPA in childhood is important. Addressing risk factors as well is important, particularly things related to obesity and triglyceride-rich lipoproteins. For those with more advanced disease, think about like hypertension, combination therapy. And if we do that together, we can move health systems away from treating disease to preserving health. And with that, I thank you, and I'm happy to take questions. Thank you.
Excellent, Coach. Thank you so much. We love to continue listening to your lecture and commenting. But, well, I will ask just a question. What kind of barriers could you find in implementing the strategies?
Very good question. Thank you. So I think one of the biggest things is we have to basically, we as doctors have to engage with health providers and governments. We need to explain this. They all know this is a problem. They just think basically treating disease later on is the way to go forward. And that's not true. We can offer them solutions. We can offer them financial savings. And that basically means little bits starting early for the future. And they will agree with that because that can be done easily through our schools, through our educational systems. Then you've got public health policies. We need to offer them something and say that if you do this now and raise public awareness, we empower patients, we will avoid some of the things later on. And you've got to offer them cheap, low-cost solutions. We have that. And we've got to tackle social media, misinformation, a lot of nonsense about this, and start to talk about cholesterol lowering as a solution in a way that patients understand.
Thank you. Very clear. Thank you. Pablo, do you have some question?
Yes, Coach, thank you very much for your outstanding lecture. I have a quick question. Just what do you think about the ways that we could have across the data and technology just to help us to fight against cardiovascular disease in this setting?
Yeah, so that's again another, I think technology will be a hugely important part of this. And it is worth, particularly in large geographical areas where you have different people scattered around, countries, maybe with not immediate access to healthcare, where they have to go further away. Apps, patients being much more aware of risk and benefit. So, when I talk to patients, I show them graphs of risks and benefit and trajectories because the numbers don't mean very much to them, but we have to engage with them. Having people accessing their own data is going to be very important because that allows us to communicate across large differences. Being able to monitor these things individually, we need to empower patients to do that. We can also use, for example, where you've got electronic health systems, we can run algorithms. Christoph in my group, for example, has done this for FH, he's done this for LPA, because doctors and health systems might say, my God, do I need to test everybody? I don't have time. Let's make it easy. You can run a software algorithm on a cloud where you have that data, and I can give it to both of you and say, these are your patients, these are the ones that you prioritize, the number need to screen is now small. So actually you're offering the health system a low cost, high yield, practical solution. And as we get more people used to, for example, managing their health, thinking about ordering medications. I mean, how many patients this week said to me, oh, I can't get an appointment with my doctor, I'm really running out of prescriptions. And I showed them my own one, NHS app, digital. When I'm running out of my statin or, medications 2 weeks before, send a message to my GP, that goes automatically to my pharmacy and I pick it up, right? We've got to train people to understand and think about this.
Okay, thank you, Coach.
Okay, so thank you so much. And next time, this will be in person here.
I look forward to it, and I wish you all a wonderful conference. Keep up all of your good work, and you've done some amazing things. What I've seen and what I've witnessed over the last 10 years, keep growing, keep doing what you are doing, and we'll make the world a better place.
Okay.
Thank you very much, Coach. I really appreciate you, and on behalf of the Argentine Lipid Society, thank you again.
Yes.
My pleasure.
Bueno, muy bien. Terminamos entonces, lo despedimos con mucho gusto al doctor Kosh Rey. Le agradecemos. Así que now you are free to go to your airport.
Great, thank you.
Bye.
Bye-bye.
Thank you,
Take care.
Coach. Safe travels. See you in London in a couple of days.
You will. Take care.
Good,
Bye-bye.
good travel.
Bye-bye.
Thank you.
Thank you.
Bye.